Afternoon, everyone. I am happy to see many of my junior colleagues, my senior colleagues, friends, co-residents. So many of them, they are around. And most importantly, what I realized was while I was interacting, I guess we were at a stationary place and our students are moving ahead. So I am really happy for them. I am proud of them. I wish them all the best. And they are doing in various areas, mind you. All of my students, every time I meet them, they say, I am working in this particular subspecialty. Now remember, neonatology is the first subspecialty. I don't call it as a super specialty. So you will have to keep that in mind. And another important thing I always tell my residents or the postgraduates is, be a good generalist, then only you will be a good subspecialist. Otherwise, it's not possible. These two don't go hand in hand. So that you have to keep in mind while you are developing yourself. But it is good that in Marathwada region, now Sunil was introducing me, but that introduction is mandatory because wherever I go, they ask me, what is your biodata? Let me be very frank with you, I don't have anything written in terms of biodata. Like the Pradeep keeps it there, so many these things and all that, I don't keep that. But most importantly, wherever I go, another message which I want to convey out to all of you is, whenever I interact with faculties, the scientists, the neonatologists, international people, I speak to them to see what can be taken from them and extrapolated to my setting, our region. Can we adopt it? If I cannot adopt it, I just forget it. And I always tell my residents that the things which you cannot practice, don't read it. Things which don't help you in exam, don't read it. All that is rubbish and you must burn it. The degrees don't matter when you enter the private practice. It's many other aspects which matter, so they have to develop professionally. They have to be always see them as in a role of a consultant. What happens in resident phase, what happens is we have gone through the residency phase. Anu is here, Dr. Khadke was my colleague during my residency days. So we used to be juniors and subordinates. म्हणजे सरांनी ऑर्डर केलं तरच त्याचं तसं म्हणजे तसंच करायचं. सरांनी सांगितलं याच्या कॅरोटीड दाबून टाकले. मग सरांनी सांगितलं ऑर्डर आहे त्याची. We were not supposed to challenge our teachers. Now many of the English students I am seeing here, I am a student of Professor Dahat. Borgavkar madam was our teacher. My best teacher was, of course, Dr. Gujarati. Unfortunately, he is not here. Irani madam I worked with. But what I learned was questioning the teachers. You need to question your mentors, question your teachers if you are not understood anything or you think that it is irrational. Otherwise, the irrationality multiplies. And it is a very dangerous kind of a thing. We teachers, as a professors and HODs, we have a super ego, I must tell you. Every resident must come, salute me, then only I am happy. But in my department, I have stopped that culture. Those days might be it was there, Sunil knows it, Kiran knows it, Sandeep was there, Om was there. But the times have changed, I have tried to adapt. It's really the honest confession of myself to all of you. But that is a challenge for me, changing myself and realizing that we can be questioned. And secondly, I never ever call any resident or share with them or do parties with them. Because I have found that That is not what is, I mean, it is really something which we need to avoid. That is what I avoid nowadays. Those days, Shivaji Rao also knows it. We used to have the parties with our teachers. But those days are different. Those kinds of teachers are not there. Those kinds of students are not there. So it is both ways. So with these few words, I congratulate these MARPCON organizers, Dr. Girish, Dr. Sandeepan. Sandeepan, in fact, one who insisted that I must come. Kiran was there. And of course, Aradwada sir, he just asked me, you just register. He came to Aurangabad and asked me to register. So that day, within 5 minutes, I had to register and send him that, whatever that receipt or whatever was there. My lecturer did that. So I really appreciate you, sir. I always love, but nowadays I have stopped moving around Marathwada and focusing my department. I'm focusing more on my department because since it is a DM Neonatology department, I need to focus more. We need to academically match the standards which are expected of a DM teaching institute. That is little challenging as the new departments they know. Because then only it will be a sustainable thing. Otherwise it will not be a sustainable thing. And I always tell my associate professor, lecturer, that the system has to work, system has to be strengthened, individuals should not matter. असं नाही व्हायला पाहिजे की देशमुख सर गेले आणि ते डिपार्टमेंट बंद पडलं ते. असं नाही व्हायला पाहिजे. Then I have failed. So I have to generate a few more associate professors, few more good teachers, and see that we maintain the standards. कारण माझे जे स्टुडंट येतात आता, what I miss is I miss undergraduate teaching. I miss the new postgraduate, fresh postgraduate. The fresh postgraduate हा conceptच नाही आता. Everyone is 3 attempts of NEET, 4 attempts of NEET, and then super specialty also there are 4-5 attempts. So my students are, I mean really they are not moldable. They are already themselves, they are consultants and super consultants, and then I have to mold them. So that is also a challenge. I'm just telling you what challenges I face. It is very good in biodata that the first DM was started in GMC Aurangabad, the first department was established, but it took 22 years for me after completing my DMs. So it is really painful. Anyways, so the topic which was given to me actually by Sandeepan was sir, neonatology discussion. Even in the pamphlet it is there. He said that sir, तुम्हाला जे काय ठरवायचं ते तुम्हीच ठरवा, बोला तुम्हाला ज्याच्यावर बोलायचं. Now one more important thing which I miss and which occurred to my mind subsequently, the panelist, I must tell you, what I miss is the presence of obstetricians. For me, nowadays, any neonatology discussion which happens, which used to happen and I used to enjoy also. We used to discuss intensive care, various high frequency, and all kinds of modes and all those inhaled nitric oxide and cooling and all those we discussed day in and day out. But as I progressed, now I am coming to the point why I have chosen this topic, Sandeepan. I spoke on this topic in 2016 for the first time in front of obstetricians, not pediatricians or neonatologists. In Aurangabad, that is the situation. जेव्हा केव्हा pediatricianला वाटतंय की काहीतरी obstetricianला सरांनी सांगावं, तेव्हा ते सर तुमचं एक लेक्चर ठेवून दे म्हणतात. But this is what started in 2016. And subsequently also, in 2015, as you know, WHO came out with those guidelines on interventions. Now we know in India, there is a large burden of neonatal deaths, and when are those deaths happening? The deaths are happening maximally around the time of birth. So death of stillborn is a death, a early neonatal death or intrapartum death is a death, and the maternal death is there. So three things are happening at birth. And on the top of that, during that period, whatever care is given, it matters for that baby for rest of the life, for preventing disability. So there is a quadruple gain by focusing on perinatal period. And that is why my focus is always on perinatal period, because the journey starts from there. In fact, it starts very early, but if you look at some of the high impact interventions, as I have shown here, they are targeting the intrapartum care. Not in the care, of course the care of small babies subsequently is also important, but most important is that perinatal period. So we'll have to target that. And that is why I have chosen this topic. I always mention this. We should be aware of this class of recommendations. You must have seen in the NRP guidelines. This is from the NRP guideline itself. And this is from the Cochrane. This hologram or whatever you want to say is of a Cochrane. Now this is from the first meta-analysis which was carried out in 1982. It was of course changed subsequently, but most importantly this diamond remained on the left side. I will tell you subsequently what is that diamond means. I have just put up a case. All of you know, you deal day in and day out. A preterm baby, maybe 28 weeks, 27 weeks, 26 weeks or whatever, delivered by emergency C-section, preterm labor in the mother, regular visits, but had PPROM 10 days back. Received one complete course of antenatal steroids, last dose before 8 days. Baby requires resuscitation in the form of positive pressure ventilation at birth. Baby had tachypnea and retraction. This is the scenario. Now, I have just made up this scenario. This is not from one of our babies. We get multiple babies every day. Now, coming to the panelists, the expert neonatologists, all of them are there. All of them I know. Nadini I know since long. She is a very good academician. Sandeep was my student, very passionate, very methodical, very hardworking. Om was with me. He is very calm and quiet, but sincere. So I start with Nadini. The first question, apart from antenatal corticosteroids, what are the potential interventions which need to be done to improve preterm outcomes?
Okay, other interventions apart from antenatal corticosteroids are antenatal magnesium sulfate, tocolytic therapy, which hasn't shown to be much beneficial, but magnesium sulfate has to be shown to be beneficial in prevention of cerebral palsy in the future life, and antibiotics for the mother, because since this mother had a 10 days of PPROM, giving selective antibiotic, and most important to remember is not to give amoxiclav to the mother because it increases the incidence of necrotizing enterocolitis in a baby. And delivery in a tertiary care center. A 29-weeker should be delivered in a tertiary care center where the other facilities for the baby are available.
Yeah. Now you mentioned some of the antenatal interventions. There will be some intrapartum interventions also. Can you take us through that also in this, Sandeep?
Ma'am has told about maximum antenatal steroid and some interventions which are intrapartum is delayed cord clamping we can consider, which can improve preterm
Yeah.
outcome. Then thermal care of the child.
Yes.
That is immediate skin to skin contact, IKMC, and delivering the child and in the post-neonatal period, considering the early respiratory support in the non-invasive manner, improves the preterm neonatal outcome. And more importantly, I want to add is antenatal care of a mother.
Yes.
Before conception and during conception, like
Yeah.
iron folic acid supplementation and improving the nutrition of the mother.
Yes,
So that
you are right.
preterm birth only will be avoided.
Yeah, absolutely. Now, these are the interventions which the WHO has given. Some of them they are antenatal, some of them intrapartum and immediate postnatal period. Mostly perinatal period. So antenatal corticosteroids will be discussing, tocolytics plus minus, magnesium sulfate. That is why I mentioned, Sandeep, that we need to have an obstetrician. I would have been very happy to challenge the obstetricians. Optimal mode of delivery is another important aspect when you are managing the preterm baby. Sandeep mentioned about cord management, thermal care of preterm baby, special some extra efforts or extra precautions have to be taken. Respiratory support at birth for these preterm babies and immediate skin to skin. Sandeep, I did not discuss the spectrum of those care issues. I am just focusing on the high impact interventions in the perinatal period which can improve the outcome. So, what is the role of steroids in preterm outcomes and what are the recommendations in pregnancies at risk of preterm delivery?
First of all, I would like to thank you, IIT Latur, for keeping us on 7th heaven, and sir is there to guide us all. So coming to the question, role of steroids in preterm babies. Steroids and surfactant, these are the major breakthroughs as far as the neonatal care is concerned. And sir has shown you already the logo of Bokhare. To just inform you all, that logo is based on the studies on antenatal steroids given to the mother. The studies have started in 60s, the logo came in 80s, and we are in 2023. Still we can see how the evidence getting into practices. It took 20 years to form meta-analysis, and still we are lacking in 2023 that our coverage of antenatal steroid is quite low. So first of all, we need to understand that steroids play a vital role in terms of decreasing the mortality of the preterm babies, almost like 30% decrease in mortality. The RDS, particularly the severity of the RDS, also quite significantly decreased. And along with that, the RDS leads to chronic lung disease. That also will be taken care if we have issued antenatal steroids. Along with that, there is a significant reduction, almost like 40% reduction in terms of the IVH and NAC. So all the major challenges that we face in preterm delivery, in terms of the respiratory issues, in terms of the gut issues, in terms of the brain issues, all these are taken care of. So we can imagine the impact of giving antenatal steroids. So the same message, what we need to convey to the obstetricians, and that's what we need to insist, the same thing, to make sure any mother who is at high risk of delivering a preterm babies need to be given antenatal steroids, at least one course of antenatal steroids.
Yeah. And what is the dosing schedule? Can you take us through?
So steroid schedule, either dexa or beta, 25 mg has to be given. Both are equally effective. That is one thing which is very clear. Now, second thing, when should we give it? Those mothers who are at risk of preterm delivery, who are at 24 to 34 weeks of gestation, so that is the one age group. Why we give at 24 weeks? Why not at 20 weeks, 22 weeks? Because the development of alveoli is very important. If the alveoli are not in a stage of development, not formed, the steroids are not going to help. So that's the reason the cutoff of 24 weeks, earliest is 22 weeks, but before 22 weeks, they are not going to be helpful. And then 34 weeks, why 34 weeks? Because the efficacy is maximum during that time frame. If you are doing later than that, yes, there are some side effects associated with the course of steroids, particularly if you are thinking of giving repeat course of steroids. So that time frame is important.
Yeah, you are right. Now I have just put up a summary slide of a recent Cochrane meta-analysis which was revised in 2020. And here again there was a significant effect, and this diamond represents the significant effect in favor of steroids. So it helps in multiple ways, not only mortality but morbidities, not RDS but even IVH. It reduces your other morbidities also, neck to certain extent. It reduces the severity of RDS, even if it does not prevent. And it is a very, I mean, it is cheap, dirt cheap. And the dexamethasone is widely available, it is being used. Betamethasone, of course, I am not going to discuss. That controversy is known and discussed very often. All of us are using dexamethasone only. So these are the recommendations. These are revised in 2022 by WHO. They are available from the web. So this is the dose of an antenatal corticosteroid therapy whom mentioned. So it reduces the mortality, reduces the severity, and it is a low cost, must use. Now for this, my appeal to all of you is, wherever you are going to the, obstetric units to attend the deliveries, request, humbly request, I know you cannot discuss too much with obstetricians, but humbly request them to give whatever dose of steroid you can give. I can do because I am in government hospital or government medical college, but I won't advise you to do. But you are expert in communication, so you can put it across the obstetric colleagues and insist that they should give at least whatever single dose is also there within 6 to 12 hours is good enough. It will help to certain extent. So Dattatray, coming to you, do steroids work equally in all settings? And what about using PIH and diabetic gestations? It can be gestational diabetes or type 2 diabetes.
First of all, good afternoon everybody. I am very happy to be part of this MARPCON organizing team and feel honored to share a dais with all my teachers. So coming to the question, steroids don't work equally in all settings. If we want optimum therapeutic response, so what do you mean by optimum therapeutic response is decreases neonatal mortality. It decreases decreases RDS, decreases mechanical ventilation, decreases NEC, decreases IVH. So this was the optimum response if we give the steroids from gestation age 24 to 34 weeks. If we give the steroid in a pre-viable setting like 22 to 24, there may be decrease in IVH and decreased mortality, but there was no effect on other outcomes. And coming to the late term and early term, coming to these settings, yes, there is a benefit in the terms of decreased NICU admission, decreased need of mechanical ventilation and RDS, but there was effect on NICU admission and there were hypoglycemic episodes. And coming to the maternal morbidities, because these steroids are given to the mothers. So coming to the PIH, we have to give it, provided it is 24 to 34 weeks and the mother is in preeclampsia. We can safely give the steroids. But for the diabetes, we have to be aware and we have to be ready with intervention to deal with maternal hyperglycemia. That is typically seen from second day and up to 5 days. And typically what happens is increase insulin dose by 40% roughly. So we have to be alert and managing maternal hyperglycemia typically from 2 to 5 days, and we have to monitor the hypoglycemic episode in newborn also.
Yeah, you are right. It's not a contraindication. If mother has PIH or diabetes, it needs to be managed. But what I want to highlight here is, what I put up this question was, as he has mentioned, it doesn't work equally well in all settings. For your information, WHO conducted first study 7-8 years back, which was called as ACT study, ACT, which was carried out in low and middle income countries to see efficacy of steroids. Now in that study, the dexamethasone treated mothers and the babies had higher mortality, and so the recommendation was very vague. And then they conducted another study subsequently, which was called as Action 1 study, where they found that it works in LMICs also, low and middle income countries, provided they have given this conditional recommendation that unit where the babies will be managed should have basic services for managing the preterm babies. Not that you need to manage 27 weeks or 26 weeks babies, even for babies who are 32, 31, 30, you need at least CPAP, if not ventilation. You need all other supports, particularly the temperature management, feeding, KMC, all this has to be there in place before you give that. And most importantly, what I mean is the prediction of preterm birth and accurate assessment of gestational age, it remains a problem. So if your assessment of gestational age is correct and your prediction of preterm delivery is correct, then only use steroids. Otherwise there will be overuse of steroids and lot of problems. So I am not going to lecture the obstetricians to say how to predict preterm labor. आमच्या घरात आधी भांडणं सुरू होते. So Sandeep, coming back to you, can a repeat course? What is your opinion and use in late preterm gestation beyond 34 weeks?
First, we should know what is complete course. Complete course is 4 doses of dexamethasone has been given. And see, our mind is always we want more and more. So what happened is obstetricians try to use multiple courses of steroids. And multiple courses of steroids were used. Then some studies were conducted, and in that studies it has been shown that it has caused more harm rather than its of more use. So the harm in the form of fetal harm and harm in the form of maternal harms. So what are these harms we should know if we are using more than one course of antenatal steroid? First and foremost is decreased weight of the child, decreased head circumference of the child, decreased length of the child. Statistically significant difference was there in the studies. So repeat course of steroid is discouraged. Second important point is it has increased the chances of cerebral palsy also in babies. Neurocognitive behavioral disorders were there more common, where repeat courses, see you can't imagine, 4 courses of repeat steroids were given in one study. It has been mentioned in MFMU study which has been mentioned by WHO guidelines also. So in that more than 4 courses of steroids were used and these complications were noted. So it has been recommended in a bold line, no repeat course of antenatal steroid is used. Now just I will add one thing, then one terminology had come in trying to peeping in like what is rescue dose of steroid or booster dose of steroid to be given or not. So considering that booster dose, if you have given steroid course, complete course of 4 doses of dexamethasone, you can consider a single dose of dexamethasone if delivery is happening less than 34 weeks of gestation, and last dose of steroid to delivery interval is more than 14 days. Just I am giving one example. If you have given at 26 weeks of gestation one course of steroid and we failed to, or mother failed to deliver the baby in next 14 days, means at 28 weeks she comes again with labor pain, then you can consider single dose of steroid, not complete course. That's my answer here for first question.
Yeah.
Second question is use.
One moment, Sandeep.
Yes, sir.
Just to deal with your answer to the first question, repeat course, I have a little different opinion and the evidence is also different. You are right, multiple courses are very dangerous. But can we give a single course, repeat course?
So there are studies also comparing single course and single dose also. So few of the studies means if you go to...
I am not speaking about rescue dose, I am speaking about a second course. First is given in the second course.
Second course, Green Top guidelines, RCOG guidelines support. But
that's a single, but that has to be qualified statement because then you will have to have all these things in place. 7 days prior, clinical assessment says that within next 7 days, mother is going to deliver preterm. Otherwise, as he has mentioned, we will keep on repeating the doses. Yes, you are coming to late preterm, Sandeep.
Second, see, late
Nadini, you want to add something?
We can give a rescue course, complete course of steroid if the 7 days have been passed and she's 34 weeks plus 7
That
days.
terminology I am not using, rescue or a repeat course. Because then that is a rescue is a little different than the second course.
No, second course we cannot, but rescue course can be given.
Rescue is nothing but a single dose. Don't get confused. It's a single dose of steroid we can consider.
Now I leave that there because obstetricians are not here. So what about late preterm babies? Beyond 34 weeks.
We should know late preterm is between 34 weeks to 36 plus 6 by 7 weeks. See, in that gestation, if we consider for giving steroids, the benefits are there, but harms are more. So by weighing that, if you want answer in one line, there is no need of giving steroid course in babies who are late preterms. Because it has been found that neurocognitive disorders are more common in the babies in whom complete course of in late preterm has been given. So more than 34 weeks to 36 plus 6 weeks of gestation, there is no need of giving steroids because harms are more and benefits are very less. Benefits are only in the form of two things. That is, one is decreased chances of TTNB and hospitalization in baby, hospitalization rate is reduced. So these are the two statistically significant differences we found in the studies. So better to avoid use in late preterm.
Yeah, you are right. So there was this third trial of WHO which was published, which was called as Action 2 study. We showed that there are some benefits, but no significant benefit, but the chances of particularly hypoglycemia, they are very high in these babies. So they are better to be avoided. Bottom line, मी संदीपला सांगणार होतो की इतकं सायन्स नको सांगू, फक्त एक काहीतरी असं सांगा आपल्याला की नाही 34 वीक्सच्या आय विल नॉट ॲज अ pediatrician would support that. If obstetrician asks me, they are free to give. They won't listen to you if they have to give. But I would not suggest that at this moment we will advise. So Nandini, what is the role of antenatal magnesium sulfate in preterm outcomes?
Just one
Sandeep,
word.
तुला काय सांगायचं राहिलं हा? Yes.
See, before moving from antenatal steroid to other thing, just I want to tell you, see, in 2015-16, Nadini ma'am also has started teaching obstetricians. We used to take perinatal classes. I myself also has taken many perinatal classes, including obstetricians. But now the time has come to again teach them. Because what I am telling, when I was studying this topic at home, my wife is obstetrician, and I was telling, अगं आपल्याला चेंज करावं लागेल स्टिरॉइडचं. पहिल्यांदा तर आम्ही ग्रीन टॉप गाईडलाईन प्रमाणे 38 plus 6 weeks पर्यंत तुम्हाला स्टिरॉइड द्यायला सांगितले जर इलेक्टिव्ह सेक्शन असेल तर, पण आता अशा नवीन गाईडलाईन आल्यात. तर शी टोल्ड मी की यू आर जस्ट रिवायझिंग एकदा असं म्हणता एकदा तसं म्हणता. मी म्हणलं इट इज द टाइम टू चेंज. सो ऑल ऑब्स्टेटिशियन्स वी हॅव टू टीच नाउ द अँटीनेटल स्टिरॉइड has changed a lot. So we have to teach our obstetricians to do these things. Thank you, sir.
Yeah, I agree, but the words you are using is a little harsh. I cannot teach obstetricians because my bread and butter is through them. Secondly, I don't want any problem at home. I have not dared. What I have done is in our obstetric department, we have this, I mean, even in our own institute, now there are two problems here. Sandeep is mentioning multiple courses. माझ्याकडे तर कोर्सेस दिले जात नाही. There is no steroid. So मला तर त्याचं बॅलन्स आणायचं आहे. सेकंडली ऑब्स्टेट्रिशियन्स सोबत कम्युनिकेशन करायचं. संदीप, कम्युनिकेशन इज बेटर वर्ड. संवाद, डायलॉग, सुसंवाद कदम सर सांगत आहेत. But what I have done is now I have put a request to them, our obstetric colleagues, की आमचे डीएमचे पोरं आता वाढलेले आहेत, त्यांना ऑब्स्टेटिक्स शिकावं लागते, तुम्ही शिकवा जरा ऑब्स्टेटिक्स. I had suggested them perinatal audit meetings or perinatal meetings. They were scared. ते देशमुख सर येतात, काही पण बोलतात, मग काहीतरी सांगतात. So they avoided it for 5-6 years. But now I requested them that you take lectures for our DM students and faculties. And what we have done, second thing is, Sandeep, Nandini knows it, One of the DM student got this NRP instructor course, she passed and she is an official instructor of NRP. I said that first start with your obstetric residents. Take them, now we have planned to take 63 residents are there in one go in obstetric department. Every year 21 students are admitted, for your information. So we have taken up that, and already we have completed 40, 50 I guess. So I guess 10 students are still left. And then we are going to take the obstetric faculties. That we are going to put in the official, that thing, no? You are
Yes, sir.
entering the data, I will be part of that.
Yes, sir.
You will be training me. Yeah, Nandini, coming to antenatal magnesium. Sandeep, तुझं झालं ना आता? मी ऑब्स्टेटिशियनला टीच करतो म्हणू नको.
So antenatal magnesium sulfate is most important for the fetal neuroprotection. Its studies have been done for the less than 32 weeker, but maximum studies were less than 30 weeker. So it is recommended up to 32 weeks. The mother who is going in preterm delivery should receive imminent preterm delivery. Like within 12 hours she is going to deliver, they should receive magnesium sulfate. It decreases the chances of cerebral palsy and combined birth asphyxia and morbidity. And number needed to treat is 41 to prevent 1.
Yeah.
So it is very important to give magnesium sulfate.
Yeah, you are very right. I am not going to tell you the details of the mechanism. मलाच कळत नाही ते mechanism. पोरं सांगतात मला सर ते हे करते फ्री रॅडिकल असं करते ते ब्लड फ्लो वाढवते ते whatever. But the basic thing is magnesium sulfate reduces the risk of cystic periventricular leukomalacia, which is very damaging. Periventricular leukomalacia म्हणजे ischemic damage असतो preterm babies मध्ये, but it is more so if it is cystic, and that is decreased. Not all PVLs are decreased, and that is why the severity of CP or the CP chances are less. So you are right, Nandini. So Dattatray, what is the recommendation?
So
If at all, because one thing I must tell you, this story of magnesium sulfate started with, not with term babies, Sandeep. It started with PIH mothers. And then it was extrapolated to some of the term babies in asphyxia. Sandeep's thesis तोच होता. Randomized control trial in uncontrolled conditions. Randomized control trials in uncontrolled conditions. He was my PG student, so he did that magnesium sulfate. He presented that in national conference. But again, those were the days, 15, 20 years back. 2006. Those days we did a randomized control trial in GMC Aurangabad. You should be proud of that. But this started with that PIH, and then that was extrapolated. So, Dattatray, yes, what is the recommendation for decreasing the morbidity and mortality?
There are two recommending bodies, RCOG and ACOG. RCOG differs from ACOG only gestation. So by and large, less than 32 week mother with imminent preterm birth, we can give the magnesium sulfate in the dose of 6 gram loading dose over 1 hour, followed by 2 gram per hour for next 12 hours or till the delivery. But adverse effect noted are usually it is safe, but if the levels of magnesiums are more, they are clinically seen with respiratory distress, DTR reflexes and cardiac complications. These are seen usually 4 hours after the magnesium loading.
Yeah.
And in the newborns, they may be hypotonic or they may have respiratory depression, but usually by and large it is safe, rarely reported.
Yeah, and sometimes they may become hypothermic, but we have not ever observed. I cannot tell you offhand, unit-wise the policy change in medical college. It doesn't remain that one unit is or one department is using. Some of the babies do receive just for prevention of cerebral palsy, not for PIH. Now that is a little difficult for the obstetricians to digest. मग बेबीसाठी गणेशने जाऊन सांगितलं तर ऐकतं, सिनियर पिडियाट्रिशियन आहे मग, पण आमच्या ज्युनियर पोरांना ऐकतील का नाही सांगता येत नाही. But that is very important, particularly as we are delivering babies of 26 weeks, 27 weeks, it becomes all the more important that that has to be inculcated as very good practice. Secondly, here I have quoted the SCOG, SOGC and RCOG. These are guidelines. Now we were discussing vaccinology today morning. Very confusing for me. I don't deal with vaccines. आणि तुम्ही ते काय इम्युनॉलॉजीचे सांगता, TH1 ते काय 18, 17, 4 काहीच कळत नव्हतं मला. बट द गाईडलाईन्स आय टेल यू, द गाईडलाईन आर नाव इफ यू नो द हायरार्की इव्हिडन्स. हायरार्की ऑफ इव्हिडन्स म्हणजे बेस्ट इव्हिडन्स कोणता, मेटा अनालिसिस, सिस्टमॅटिक रिव्ह्यू, देन RCTs, देन द कोहॉर्ट स्टडीज, केस कंट्रोल ऑर नॉन रँडमाइज, व्हॉट एव्हर दॅट इज, अँड द एक्सपर्ट ओपिनियन इज खाली. आमच्या वेळेस एक्सपर्ट ओपिनियन आधी असायचं, म्हणजे एक्सपर्ट नाही ते काळ्या दगडावरची रेष. बट सो दॅट इज ॲट द बॉटम नाव. सो डेज हॅव चेंज्ड. बट द गाईडलाईन्स, माइंड यू, इन द एव्हिडन्स हायरार्की, इफ यू सी द न्यू द pyramid which is there is a clinical guidelines at the top. And why that is so? Khadke was there as a part of preparing those CIP or kudla pustak leta hai sir tumhi. So he was preparing those guidelines, and no, I am just coming to the point. Those guidelines, not only they look at meta-analysis, the evidence per se, but they do grade analysis for all of you. And secondly, what they do is, when the guidelines are issued by, say for example, IAP or NNF, they are adapted to the local conditions. India, and the challenge for all of us is, India guidelines वर आपल्याकडे काम करतील अशी काही गॅरंटी नाही. म्हणून मला मराठवाडा गाईडलाईन्स ते सुद्धा माझ्या युनिटचे गाईडलाईन्स वेगळे करावं लागतात. But I should not deviate from the science. That is the challenge. So we'll have to adapt and readapt. That is the skill. नाही तर हे इतकं कन्फ्यूज करतात ना, दर 6 महिन्याला एक वॅक्सिन नवीन सांगतात, हे टोचा ते टोचा. I'm not criticizing the vaccinology. So coming to place of delivery in improving outcomes, is it important, and how significant it is, and what is the significance, and what additional resources needed? When you are going to the obstetric suite or obstetric unit, I mean, you are attending 26, 27, 28, 29, 30, whatever. So what additional resources are required? So 2 questions of it. Place of delivery, does it matter? Yes, but what is that?
So I'll start with time of birth, importance for the parents to make the kundali of the baby. Place of birth is going to decide whether the kundali will be good or not. So that is one way I'll put. So whenever we go for a resuscitation of a baby, we should think of 3 points.
One thing again about place of delivery, because I always look at a broader perspective. Now in India there are multiple Indias and multiple Hindustans and multiple Bharats and all that. But what I look at is, place of delivery means whether it is an in-house or inborn or it is an outborn. For fragile babies, very preterm, extremely preterm, it is preferable that you manage that baby or delivery occurs in a place where there is an in-house facility for managing such types of babies below 28 weeks. And the unit has an expertise, some expertise in managing ELBW babies. नाही तर आजकाल तुम्ही पेपरमध्ये छापता 400, 500, 600चे, आमचे पोरं लगेच म्हणतात आपण पण सर एक 600, 650चं करू. That is not my target, I say. It may become a very good headline for a newspaper, but it's not my target. My target area still remains maybe 900, 800. We have gone down on 800, 900. We are surviving those. Atul is looking at me, sir, कसं काय सांगायलेत आपण ते इतके सर्वाइव केले होते ते 650, 800, because I don't want to look back again with them. 2 वर्षांनी 3 वर्षांनी ते कसे झाले मला नका दाखवू म्हणतो मी. So it is going down. So in such a scenario, you advocate in utero transfer. You advocate those mothers, communicate with obstetricians that deliver this mother in a unit where there is level 3 facilities are available. Otherwise, it will be very misery and the transport and everything is a mess. Yes, you were telling additional resources.
So I was saying 3 components that we should remember for all deliveries for that sake. PPE, I'm sure all of you are familiar with this.
I am not going to finish this till 5 o'clock. So I am going to take another 5 or 10 minutes. Buttered sir, with your permission. मला माहिती आहे भूक लागलेली आहे, पण मला जास्त लागलेली आहे. शिकवायची नाही, शिकवायची माझ्याकडे आहे जीएमसी मध्ये. भरपूर आहेत माझ्याकडे.
So I was talking about PPE. All of you are aware of PPE during COVID times. First P is the personnel who are going to be there for delivering the baby. So there should be someone who knows intubation and managing preterm babies. That is very important. Second part of the PP, second P is the place of birth. As sir rightly said, it should be the in utero transfer to the place where there are facilities available to manage the preterm babies. And the place, the immediate place, if you think of the temperature, the environment, the clean environment is what is important in terms of the preterm babies. And the E part is the equipments. And as you know, we have seen in earlier discussion also, the delivery room CPAP is very important. The oxygen that we are giving for these babies should be a titrated oxygen, so we'll require a blender. Thermoregulation is going to be challenged, so maintaining environmental
So it's very
temperature.
important, as he is pointing out. I do not know how many of obstetric suites, even the medical college, we are struggling to give the blended oxygen. Controlling the FiO2. आम्ही डिस्कस करतो NRP मध्ये इतकं द्या मॉनिटरिंग त्याचं पल्स ऑक्स मॉनिटरिंग करणं हे these are the things, दिस पॅराफर्नेलिया जिथं फ्रिक्वेंटली प्रीटर्म डिलिव्हरी होतात त्या ऑब्स्टेट्रिशियन्सला तुम्ही रिक्वेस्ट करू शकता की हे एक्स्ट्रा एफर्ट्स तुम्हाला घ्यावं लागतील, प्लास्टिक बॅग्स तुम्हाला कॅरी करावं लागतील, पल्स ऑक्सिमीटर पोर्टेबल आज अवेलेबल आहेत. इट इज अन इनसेपरेबल पार्ट ऑफ ए neonatologist. You must always carry them. See that there are blenders and there are these things also, pulse oximeters which are quite reliable, I mean. So Sandeep, coming to delayed cord clamping, what is the recommendation? What are benefits, harms?
Sir, delayed cord clamping is a must in preterm babies.
2 किंवा 3 लाइन मध्ये सांग.
It is having benefit in the form of increasing hemoglobin, increasing iron store, decreasing IVS, decreasing chances of NEC. But on the other hand, it is going to increase the chances of jaundice. And if we are doing in more extreme preterm babies, if we are doing milking, it is going to cause intracranial hemorrhage. And during resuscitation, delayed cord clamping is actually definitely useful because it is going to give extra volume to the baby rather than giving normal saline bolus as you consider in neonatal resuscitation. But naturally, if you are getting bolus, it's good. But there are practical issues while conducting delayed cord clamping and while doing resuscitation. Few studies have made the resuscitation table, which is lying besides the
That I will come to subsequently.
Okay, sir.
But during resuscitation, have you ever thought of or done?
Sir, not done. I have not done.
Nandini?
No, sir.
Since you are in a teaching or tertiary institute.
No, sir, we haven't tried during resuscitation.
Anybody? Now the DCC in preterm, you पहिले try करा. DCC in term आधी try करा. DCC in preterm करा. करतात चांगले. पण आपण ने obstetricians की permission घ्या. So that is the key. And doing it in preterms, it is all the more difficult. But convince them that there are benefits. You should be convinced for that it is really beneficial. So I always tell the residents that there is a bundle of 3 things. One is delayed cord clamping, skin to skin, and feeding in term babies, breastfeeding. That goes immediately. So the base surface for managing the baby in the delivery room, warm surface, full of love, is mother's abdomen or mother's chest. Why you are taking the baby to the warmer? So that has to be inculcated in everyone. So do it first in term babies. Do it in larger preterm babies and extrapolate it to the smaller preterm babies. Have you ever tried, any of you, umbilical cord milking? Then only we will discuss. Otherwise it remains a theoretical discussion. I mean, Atul, तुला काय सांगायचं का अतुल डिलेड कॉर्ड क्लॅम्पिंगच्या बाबतीत? कारण तू सांगत होता, कोणीतरी फीडबॅक देत होते, एक सिव्हिलचे आमच्याकडे आले होते, FBNC आता चालू आहे, ते सिनियर पेडियाट्रिशियन. इट वॉज अ व्हेरी गुड ऑब्झर्वेशन की ते आम्ही बंद केलं सर, ते सगळ्यालाच फोटोथेरपी लागाली. पॉलिसायथेमिया असा सिग्निफिकंट होत नाही त्याच्यामध्ये, स्टडीज हॅव नॉट शोन. कारण त्यांनी आधी वाचले ते पॉलिसायथेमिया होतो आणि जॉन्डिस होतो म्हणून त्याला नसला तरी आहे जॉन्डिस आणि लावून टाकलेले फोटोथेरपी. सो दॅट इज व्हेरी डेंजरस. कीप युअर आईज अँड माइंड ओपन. डोंट जस्ट से की पुस्तकात आहे काहीतरी लिहिलेलं, दे कॉशन अस. बट गिविंग phototherapy for 1 or 2 days is not a big thing. Rather, so many benefits are happening, as Sandeep has told. Those are very important. So milking, anybody is doing umbilical cord milking?
No, we don't practice in our unit.
Umbilical cord milking तुम्ही वाचला असेल, but I don't think even in medical colleges we have tried. But त्याच्यामध्ये कसं असते की you just give 4 sweeps, each for 10 seconds, from the placenta side to the fetal side, baby's side, so that transfusion लवकर होते आणि बेबीला मॅनेज करायला आपण घेऊन जाऊ शकतो. But that can be done on the cut umbilical cord also. That we need to use, which can be done, because that is the basic worry. But that is a further step. आणि हे आपल्या NRP गाईडलाईन्स मध्ये आलेलं आहे कॉर्ड मॅनेजमेंटच्या. So, who is going to say Om, thermal management बद्दल काही? Anything special?
So
in 2 lines.
Preventing conduction, heat loss of the baby by conduction, convection, radiation. This is what we follow. Receive preterm babies who are less than 32 weeks in a plastic wrap, and that plastic wrap is under the warmer, which will evaporate the amniotic fluid from the baby's skin, and then that will act as a mini incubator to maintain the temperature for the preterm babies. That is one thing. And second point, which is missed many places, is the humidified air and oxygen, because that is also will help to prevent the heat loss for the baby. So for preterm babies, particularly who are less than 32 weeks, many times they do require some support. So skin to skin contact, I will say, will be careful
But
for these babies.
skin to skin, as Sandeep has mentioned already, IKMC जी study है ना, immediate KMC ची study. अब there are 2 things आहेत. ह्याच्यामुळे सांगितलं भट्टड सर हे 5 वाजेपर्यंत जाऊ शकते. The skin to skin is different than the KMC. It's not KMC, skin to skin. Remember, KMC has multiple components. There are 4 components. Feeding असते, त्याचं discharge असते, follow-up असतं, सगळं असतं त्याच्यामध्ये. Skin to skin is just skin to skin. So त्याची जी स्टडी पब्लिश झाली होती, anybody would like to say about that? IKMC? Nandini, you want to take? Dattatray, yes.
So it included the multi-country study was there, and India was part. Professor Siddharth Ramji from Delhi was included in that. It was on concept of mother NICU, NICU. So where the baby was put on to the skin-to-skin contact immediately after birth, and we never looked at stability of the baby. Concept is to, once the baby hemodynamically stable, then you can go for traditional continuous KMC. But here is without looking at the stability immediate, KMC can be started. Where in these 2 arms, one they able to do it for almost 16 hours average compared to traditional care. So in that what they found is mortality at 28 days was significantly less, but effect is not seen as 3rd day mortality. That was IMKMC.
So this KMC study, MNCU, हा concept एक just तुम्हाला सांगतो, MNCU, maternal newborn care units. 2019 ला, Sandeep, the government of India issued guidelines, detailed guidelines of how the MNCU should be. Now this Harish Chelani studies came subsequently, published 2020-21. But MNCU was a concept that was proposed, and we had proposed one MNCU in GMC, you know that. Unfortunately, it didn't work up. I am now going to have a 35-bedded separate kangaroo mother care ward in our unit. And in that, we are going to plan 4 MNCU beds. MNCU bed means mother, baby, zero separation. Baby will be also managed there, mother will also be managed there. So that is the concept. And that is a bigger challenge. So we need to be aware of those challenges. आता याच्यामध्ये बऱ्याच जणांना प्रश्न पडतो झिरो सेपरेशन मदर जर चांगली नसेल तर कसं यू कॅन टेक सरोगेट एनीवन कॅन सरोगेट रिलेटिव्स असतात फिमेल रिलेटिव्स असतात दे कॅन स्टार्ट गिविंग KMC. Coming to the respiratory support, I guess this is the last 1 or 2 things. It's a big topic, I mean, it is a big topic for discussion, respiratory support. So, Nandini?
Sir, TP's resuscitator would be the appropriate method for delivering PPV in a apneic preterm, since we can measure PIP and PWP both and deliver the blended oxygen. It's the best thing to avoid barotrauma and other things.
Yeah. So we need to give PEEP लक्षात ठेवा. प्रीटर्म मध्ये resuscitate करताना बॅग अँड मास्क नुसतं चालणार नाही. एंड एक्सपिरेटरी प्रेशर लागतं. FRC डेव्हलप झाली पाहिजे. They are fighting with the reduced FRC. They are trying to maintain it with such a highly compliant chest and the highly stiff lungs. त्याची चेस्ट असे तुम्ही बघितलं असेल रिट्रॅक्शन सिल्वरमन अँडरसन whatever. So they need PEEP and expiratory pressure. That cannot be delivered with bag mask, which we are using, self-inflating ambu bag. But we need to have a separate bag. That the bags are available with a PEEP kit in. Or you can use TPS as she has mentioned, TPS resuscitator. Yes, you want to
Yes,
say
sir. No, sir, TP's resuscitator.
Yeah, and so that can be done. And we can give in a spontaneously breathing babies. How do you support home?
If a baby is breathing spontaneously, we need to
Now,
assess
baby is
whether there are
requiring
signs of-
resuscitation, positive pressure ventilation with PPV, with TPs.
Yes. So that will be decided by, again, as Sir said, Silverman underscore score is going to be helpful. If the score is less than 3, it means mild, may not require much support. If it is 3 to 6, may have to give CPAP. That is very important. And another part of CPAP is it should be a blended air and oxygen and a measured FiO2 based, measured oxygen that we are going to give based on the oxygen saturation. If the score is more than 6, then we should think of intubation for these babies.
Yeah, so CPAP in delivery room. How many of you have tried or practiced? Yes. Can you tell us the experience? हा पण पेरिफेरीला काम करतो म्हणजे काही प्रयोग करायला आपण मोकळे नाही लक्षात ठेवा.
They don't prefer to go at the higher centers, and they ask us to do the delivery.
You are speaking about subsequent management. I am speaking in the delivery room. Immediately after birth, baby, preterm baby, if not breathing, give PPV with PEEP, with TPs. That is one thing. Second thing is baby is breathing spontaneously but has tachypnea or retractions. Then you need to give CPAP in the delivery room at birth,
Yes,
not
sir.
intubate. So that has to be tried. You can try indigenous CPAP, but it is very risky. You are giving 100% oxygen and all that. So you need to, this is a challenge. This is not a matter of just discussing. Implementation is the challenge, because you will have to have obstetricians on board. Bring your obstetricians on board. It is my appeal to you. Just either don't go with a begging bowl. You will just receive a beg. Nothing else. Go there as an equal partner. मी obstetriciansला सांगतो, there is a wellness of baby is very important. त्यांना म्हणलं तुम्ही रेस्पेक्टफुल मॅटर्निटी केअर म्हणता, रेस्पेक्टफुल न्यूबॉर्न केअर कुठे? I need respectful newborn care. So that is what I fight for. Because we need to have equal voice, and obstetricians should be concerned. असतातच ते. इन्फर्टिलिटीच्या मॅनेजमेंट असते, प्रिशियस बेबीज आजकाल सगळे आहेत. So they are worried about the baby's outcome. So tell them all these things. Have a session with your own obstetrician. Then only the change will happen. And it is not going to be sudden change सगळीकडे झालं. Small changes होणार ते individual level वर. So can you use NIV? Have you tried any time? In labor room, at birth, or spontaneously breathing?
So NIV is not a primary mode of ventilation. So CPAP, where we know the PEEP that we are going to deliver, but NIV, the high flow nasal cannula, what we are talking about, is not the primary mode that will be preferred.
Atul, you want to say something about NIV at birth? Have you tried? अरे त्याला मास्क द्या, हे द्या ना, माईक द्या त्याला.
We use NIV in labor room, as sir said, in preterm babies who don't.
He is from our unit, associate professor. ते जास्त हुशार आहे, त्याला विचारा तुम्हाला काय विचारायचं.
And after stabilization, we transport the baby to NICU. We use primary mode NIV as respiratory support in newborns, even in labor room also, and in NICU also.
Now that was feasible. एक गोष्ट तुम्हाला सांगतो side show म्हणून. That was feasible for me because I was struggling how to give that NIV. कारण तुम्ही TPSनी NIV देऊ शकता, पण then you need to have somebody. याच्यामध्ये तुम्हाला नेझम प्रॉन्स लावायचे, सेटिंग करून ठेवायचं झाले. पण आम्हाला कोविडमुळे 350 व्हेंटिलेटर मिळाले, त्याच्यातला एक व्हेंटिलेटर आम्ही लेबर रूमला ठेवलेला आहे. So we are giving, that is a luxury. And I won't advise you to take your ventilator to obstetric unit. So that we have tried, we have done that. In our unit, we use NIV as a primary support in NICU. That is a different story. So this is what is there. Oxygen, you know, we use with 30%. I'm not going to go. Pulse oximetry, have you used any time in labor room? You are using. So what precautions you have taken? Do we get the readings? The readings are वेळ लागतो. Pulse oximeters.
Choice of pulse oximeter is very important there. The pulse oximeter with set technology, with less motion artifacts and less light artifacts. Massimo.
Massimoने काय तुला दिलं होतं का काही?
नाही.
Conflict of interest है.
Cost is equal, sir. And second thing which we found is connection between the means baby.
त्याला असंच बोलतो, त्याला माहित आहे तो माझा स्टुडंट आहे. नाही, he is very right. Massimo we are using. Massimo we are also using, but the important thing here is Sandeep. Yes.
Connection is because first we have to put on the palms.
Very important.
The sensor should be put on the palm, and there will be in between connector will be there between the monitor and the probe. So that in between connector should be connected later. So signal acquisition will happen fast, and you will get readings as.
Start using portable pulse oximeters wherever we go. Neonatology practice करताना एक pulse oximeter, एक transcutaneous bilirubinometer, the pen torch, हे part of your paraphernalia. Stethoscope नि काय ऐकू येतं? काय मला तर काहीच ऐकू येत नाही.
Excuse me, sir. Excuse me,
So this
sir.
is the summary of whatever we have discussed.
ऐकू गेलं सरांना.
So this is what Sandeep was saying. Livestock trolley, very costly आहे. तुम्ही घ्यायचा प्रयत्न करू शकता to keep it in obstetric unit, but it can be indigenously made also. This kind of a thing. ट्रॉली चालली वर, बेबी त्याच्यावर ठेवलंय, कॉर्ड इंटॅक्ट आहे, इंटॅक्ट कॉर्ड रेससिटेशन होते, वॉर्मिंग होते, सगळं होतं, मॉनिटरिंग होते, NIV दिल्या जातं. इट्स कॉस्टली.
Excuse me, sir.
So that's it, friends. Is it over? You want to say something?
May I request?
Thank you.